This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is What You Should Know About Colon Cancer Screenings and is sponsored by the American Cancer Society. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We'll answer as many questions as we can within the time allotted once the presentation concludes, and your questions will remain anonymous as always. Today's presenter is Dr. Ramona Rajapaksa. Dr. Rajapaksa obtained her medical degree from the Royal College of Surgeons in Ireland. She is a fellow of the Royal College of Physicians in England and a fellow of the American College of Gastroenterology in the United States. Prior to joining Mather Gastroenterology, she was at Stony Brook University School of Medicine, where she was on faculty in the Division of Gastroenterology for 20 years. At Stony Brook, she was the director of the Inflammatory Bowel Disease Center. She's partnered with the Crohn's and Colitis Foundation to educate the community and fundraise for research. And in addition, she is active in the National Public Policy Council of the American College of Gastroenterology. She is board certified in gastroenterology and has a special interest in inflammatory bowel disease and women's health issues, in addition to general gastroenterology and colon cancer screening. Dr. Rajapaksa, you can go ahead and get us started. How are you today?
Hello, good afternoon. Thank you. And thank you for inviting me to speak. Good afternoon to everyone. It's kind of strange doing this on Zoom because you don't see an audience. So I feel like I'm talking to myself. But the title of my presentation today is Colon Cancer Screening and Prevention. Part of this talk has been presented last year by my colleague and myself. I work at Mather Gastroenterology. So the first thing I want to start with is this question of screening. Why do we bother screening? Well, you know, if a disease is very common and if it can lead to death, if it is untreated, if the disease can be detectable before symptoms actually appear, and if treatment is more effective if the disease is caught early, then screening works and can save lives and reduce morbidity. So that's the reason we screen. Now, there's this entity called lead time bias, because some people sort of say, well, just because you detect it early, does your actual lifespan increase? Are you going to live longer just because you detected it early? And that depends on whether early treatment is effective or not effective. So, for example, if you take certain types of brain tumors, whether you detect it when the patient is symptomatic, or whether you detect it early by some other means, ultimately the lifespan is unchanged because there is no effective treatment. On the other hand, if you take a disease where early treatment is effective, then if you detect it early and treat it, you will get improved survival. So you need a situation where there is no lead time bias in order for screening to be useful. The other thing you need is a good test to detect the disease early. So we talk about a test having high sensitivity and specificity. Sensitivity is a test's ability to detect all patients with the disease, and specificity is the ability to exclude patients who don't have disease. So typically you want a test with high sensitivity, high specificity, a high predictive value, and the test has to be relatively safe because the benefit of the test should be much greater than the risk. So colon cancer actually lends itself to this kind of screening. It's really an ideal target for screening because it's a common cancer. It's lethal if it's left untreated. There is a precancerous phase that can be detected. We have good tests to detect it. And if you treat it early, it has a good prognosis. Colon cancer is really a significant public health problem. It is the second leading cause of cancer death in the United States in both men and women. There are about 150,000 new cases each year in the United States. About 9% of all cancer deaths are due to colorectal cancer. And the likelihood of anyone developing colon cancer during their lifetime is 1 in 20. So that's pretty high. It causes 40 to 50,000 deaths per year. And the most alarming thing is that the incidence is rising in younger age groups. So since the 1990s, the incidence has doubled in patients under the age of 50 for no known reason. And these are graphs taken from the American Cancer Society, and I want you to just sort of look at the two top graphs. These are patients aged 0 to 49 between 1995 and 2016. And as you can see, both in males and females, there has been an increase in incidence of colorectal cancer in this younger age group. And there has also been mortality. Although the mortality hasn't changed a lot, but the cancer rate has increased. On the other hand, if you looked at ages 50 to 64, and particularly in the older age group, over the age of 65, the incidence and mortality has actually gone down. So what is colorectal cancer? It's cancer of the lining of the colon. The colon is also called the large intestine, and cancer of the rectum. And this is, a representation of what the colon looks like, the different regions of the colon. And it can be influenced by both genetic and environmental factors. As I said, 90% of cases occur after the age of 50, but the incidence is rising in the younger age group. And the overall 5-year survival rate is approximately 61%. So what are the risk factors for colorectal cancer? Well, there are both changeable and unchangeable factors. So the changeable factors are things like weight. Obesity is a risk factor for colon cancer, and lifestyle factors such as drinking excessive amounts of alcohol, cigarette smoking, and a diet that's high in processed or red meat. On the other hand, there are also unchangeable risk factors. For example, a family history of colorectal cancer. There are certain cancer syndromes in which colon cancer is more common. A family history of colon polyps or inflammatory bowel disease, ulcerative colitis or Crohn's colitis, can both predispose to colorectal cancer. So if you have any of these unchangeable risks, then you should start screening early for colon cancer. So what are the symptoms? Well, the most important thing to know is that most colon cancer is actually asymptomatic in its early stages. In its later stages is when you usually have symptoms, and some of the common presenting findings are constipation, weight loss, bleeding, anemia, lower abdominal pain. Now, early treatment for colon cancer is better, because survival depends on the stage of the cancer at diagnosis. So staging of colon cancer is numbered as 1, 2, 3, 4 with modifiers A, B, and C, and each stage depends on certain variables. We also have the TNM system, which is based on the local extent of tumor infiltration, whether there's lymph node involvement or not, and whether there are metastases. That's what TNM stands for. And this is a diagrammatic representation of the TNM staging of colon cancer. These are the layers in the colon, mucosa being the innermost and serosa being the outermost, and there are muscle layers in submucosa. And so you can see stage 0 is the earliest, and by the time you get to stage 4, it has gone through all the layers of the colon wall and spread to other organs and spread to nearby lymph nodes as well. So we want to try and catch the colon cancer, detect it at its early stage when treatment is better, or preferably before it is even colon cancer. So 5-year survival depends on how early colon cancer is diagnosed. Survival is directly dependent on how early the disease is found. So for example, if you detect in stage 1, there's a 93% 5-year survival. If you detect at stage 4, it drops dramatically to about 8%. Similar findings in rectal cancer at stage 1, it's anything from 70 to 90% 5-year survival. And by the time you get to stage 4, it's anything from 5 to 8%. So it underscores the fact that early detection is best for survival. So when did we know and how did we know that colon polyps cause colon cancer? and that colonoscopy helps to prevent colon cancer. Well, this all started with this landmark study that was published in the New England Journal of Medicine by Sid Winauer and group, Prevention of Colorectal Cancer by Colonoscopic Polypectomy. And essentially what they did was they had a cohort of patients that had colonoscopies and polyp removal, and they were followed for a period of 5 to 6 years. And they compared them to a historical cohort of patients, 2 from the United States, the Mayo Clinic and Sears, and 1 from the United Kingdom. And these patients had not had colonoscopies, and some of them actually had known polyps detected through barium enemas before the era of colonoscopy and polypectomy. And what they found was they observed the incidence of colorectal cancer in the polyp study cohort with that expected in the other groups. And they found a very marked reduction of incidence in colorectal cancer in the polyp cohort group compared to the control group, which was statistically significant. And you can see this in this graph. It's a little easier to understand. This is the number of colon cancer observed in the polyp study cohort, and this was the number in the Mayo Clinic and Sears data. So this study basically supported the fact that colon cancer starts from a polyp, and that polypectomy prevents colon cancer. And it's one of the best studies that we have to date to show that, because really it is unethical to do a randomized study on something like this, because you have to offer patients the option of having polypectomy rather than leaving them to keep their polyps. So you might ask, what's a colon polyp? Well, colon polyp is a little growth that you can get in the mucosa. Many colon polyps are precancerous growths, and they have various morphologies and various terminologies: adenomas, villus adenomas, tubulovillus adenomas, serrated polyps, and so on. They occur in approximately 25 to 30% of people at age 50, and some studies have shown rates as high as 50% in patients aged 70 and above. And not all polyps are precancerous, but many polyps are precancerous. And colon cancer develops from colon polyps, which are asymptomatic. So this is another, I showed you earlier, a flat polyp. This is a polyp with a fat stalk, and this is more or less a sessile-looking polyp. And so removal of these types of polyps helps to prevent colon cancer, and that's what we do during colonoscopy. Now, only 1 to 4% of people at the age of 20 to 30 have colon polyps, but this increases with age. And a colon polyp can become cancer in as little as 7 years, and that depends on genetics, environmental factors, and other diseases, whether the patient has inflammatory bowel disease or not. 90% of colorectal cancer deaths are thought to be preventable by early detection. So colon cancer, the progression from normal to cancer usually occurs in a controlled and orderly progression over a period of time. Sometimes that process is accelerated, again, depending on genetics or genetic cancer syndromes or other situations. So you go from having a normal mucosa to developing a polyp, colon adenoma or serrated adenoma, tubulovillus or villus adenoma, and then that becomes cancer. So this is the place where we want to intervene to remove the polyp before it becomes cancer. So what are the currently available colon cancer screening methods? Well, there's colonoscopy, there are stool tests, and I'll talk about that in a minute. There's CT, what we call CT colonography, or what is referred to as virtual colonoscopy. Flexible sigmoidoscopy is similar to colonoscopy, but only examines the lower part of the colon and doesn't go throughout the colon. And the newest kid on the block is capsule colonoscopy, which is a capsule with a camera which patients swallow, and it takes images of the colon. Now, colonoscopy, when you compare the different modalities of screening, the interesting thing about the colonoscopy is that it's the only one that not only detects polyps and colon cancer, but it can prevent colon cancer, because if you detect a polyp during a colonoscopy, you can remove it, thus preventing colon cancer. The majority of polyps can be removed during colonoscopy, but of course, if we find a very large polyp, something that can't be removed, then the patient will need surgery. And the polyps are removed either with a biopsy forceps, the thing you see here, or with an endoscopic snare, which is kind of like a lasso that you put in through the scope and burn it off. Now let's talk a little bit about the stool-based test. Stool guaiac is the oldest kid on the block, and it's sort of an indirect test for blood. It checks for peroxidase. And so it detects not only blood from the patient, but it can also give you false positives depending on one's diet. The fecal immunochemical test is a direct test for hemoglobin using monoclonal antibodies. So it's more specific and more sensitive. And the multi-targeted stool DNA test looks at multiple different targets, as the name implies. So it looks for DNA from cancer cells, things like KRAS, and it also checks for blood. So there's an FIT component to the multi-targeted stool DNA test. The important thing to understand is that all of these stool tests detect colon cancer once it is present. They are not that great at detecting polyps, even large polyps. So if you look at colonoscopy versus the DNA test versus FIT for the detection of large polyps, the sensitivity of colonoscopy is around 96%, while the sensitivity of the DNA test for detection of large polyps is 42%, and FIT for detection of large polyps is around 20%. So there are marked differences in the sensitivity for detection of large polyps. When you think about detection of cancer itself, the stool tests are pretty good if you're waiting to detect cancer. So these are two recent studies that basically came to the conclusion that the best screening test for colon cancer is a colonoscopy every 10 years, or if the patient can't because of illness or frailty, or if the patient does not wish to have a colonoscopy, then an annual fecal immune test is more effective and less costly than the multi-target stool DNA every 3 years. Now, how do we know that colonoscopy and polypectomy work? Well, this is taken also from the American Cancer Society, and it shows you the trends in colorectal cancer incidence all the way from 1970 to 2015. And you can see that somewhere around 2000, the colorectal cancer incidence fell dramatically, and so did mortality. There's some discrepancy in different demographic groups, but essentially the incidence and mortality fell. And this is around the time that colonoscopic polypectomy was first instituted and large-scale screening programs started. And in my next slide, also taken from the American Cancer Society, you can see that this is on the left axis is the colonoscopy screening, and this is the years, and this is the colonoscopy versus the incident rate of colon cancer. And you can see that as the colonoscopy and polypectomy rate increased, the incidence rate for colon cancer fell. And that's how we know that what we're doing is having an effect on colon cancer. I wanted to say a few words about what the colonoscopy involves. It's a flexible insertion tube. Colonoscopy has been used possibly since the 70s. There's a light source, a suction channel, water jets, and an instrument channel through which we put in these biopsy forceps and snares in order to remove polyps. And this is what the colonoscope looks like. So some of the roadblocks to colonoscopy, well, patients are afraid of the colon cleansing solutions. They're afraid that it tastes bad. There's a fear of discomfort, and there's a fear of complications. So for preparation, the colon usually contains a variable amount of stool that that needs to be evacuated so that we can see the mucosa clearly. What we usually recommend is a clear liquid diet for 24 hours before the procedure, something like water, apple juice, broth, and jello. Laxatives begin around 5 o'clock, and then diarrhea begins after that. Diarrhea can last up to 5 hours, but it really, and it can also start sooner, but it really depends on the patient and their own bodies. Traditional colonoscopy prep solutions have included Go Lightly, which is a gallon of fluid that one has to drink, Fleet's phosphor soda, and magnesium citrate. What we use is Miralax. It's available over the counter. It's a bottle of Miralax, 238 grams, that you dissolve in a liquid of your choice, 64 ounces of a clear liquid, anything like iced tea, Gatorade, lemonade, apple juice. There are usually a couple of Dulcolax pills as well that have to be taken together with the Miralax. What's really nice about the Miralax is that it's flavorless, tasteless, odorless, and it doesn't change the taste of the liquid that you're drinking. So it's a lot more palatable than a lot of the traditional colon cancer preps that we use. The other concern that patients often have is whether the colonoscopy is going to be painful. Well, it's painless and it's relatively fast. We use intravenous medication, propofol, that's administered by anesthesia for sedation, and the patient is usually comfortably asleep, breathing on their own. Their heart rate, blood pressure, and oxygen saturation are monitored, and usually the procedure takes about 15 to 20 minutes. It can take longer if there's removal of a lot of polyps or if the colon is particularly a difficult procedure, but normally it's over in 15 to 20 minutes. But usually the patient has to stay in the endoscopy suite for 1 or 2 hours. The entire process takes about 1 or 2 hours. In spite of all this, what we've seen is that the United States compliance data is not as good as we would like. Less than 60% of those over the age of 50 have received appropriate screening. And although this data is old, it is replicated even now. Some screening rates are on the rise, particularly due to the presence of stool tests. The DNA and the FIT have resulted in a slightly increased rates of screening, but they're still below national targets. One of the concerns that patients often had was cost. Screening colonoscopy is covered by insurance, but there was some surprise billing for Medicare patients when a polyp was removed, when it would be converted from a screening to a diagnostic procedure. But Rep. Donald Payne introduced a bill into Congress removing barriers to colorectal cancer screening to remove this aspect of billing, this little glitch that was there in the billing, and this was signed into law in December of 2021. So that's a great win. So the United States Multi-Society Task Force, which includes the American Gastro Association, American College of Gastroenterology, and the American Society for Gastrointestinal Endoscopy, have determined that there are 3 tiers of tests that are suitable for screening for colonoscopy. Tier 1, which is the one that they recommend most, include colonoscopy and FIT. The MSTF recommends that physicians offer colonoscopy first, and if patients decline a colonoscopy, then an annual FIT. If they're not going to undergo either the colonoscopy or the FIT, then you could go with the tier 2 test, which is a CT colonoscopy every 5 years, Cologuard every 3 years. The 3-year for the Cologuard is recommended by the manufacturer. We still don't have enough data to determine what the appropriate follow-up after Cologuard should be. Flexible sigmoidoscopy every 5 years. And number 3, the capsule endoscopy doesn't have enough data as yet. The capsule colonoscopy was approved by the FDA for screening patients who were very sick or who had an incomplete colonoscopy due to technical difficulties, anatomy, and so on. There are sensitivity and specificity rates out there, which are around 85%, so they don't meet the same rates as colonoscopy, and it's still under evaluation. Now, what about when do we start screening? Well, as you remember, I showed you the slide with the increased incidence of colorectal cancer in younger age groups. The American Cancer Society made the first suggestion that screening should start at an earlier age. And soon after, last year, the multi-society task force, including the 3 GI societies, also reduced the screening age to between 45 and 49 because of the increased incidence in young individuals. But of course, we still recommend that everybody between the ages of 50 and 75 should have colorectal cancer screening. For individuals between 76 and 85, it really depends on the patient, whether they've had polyps in the past, whether they have other medical illnesses that may affect their life expectancy and therefore, affect that risk-benefit ratio for the procedure, and of course, personal preference. And generally speaking, screening is not recommended after age 85. So if you want to lower your risk of colon cancer, we recommend that you eat more fruits and vegetables, that you avoid processed and red meats, that you exercise regularly, that you don't smoke, drink alcohol in excess, and that you maintain a healthy weight. And of course, the most important thing is to have a screening colonoscopy at the right time. Ultimately, the best screening test is the one that gets performed. We do have a direct access program for screening colonoscopies for patients who are busy at work and who are healthy. They can call this number, and we have a clinician who will determine if they are candidates for the direct access program. And that is all I have.
Fantastic. Thank you so much, Dr. Rajapaksa.
You're welcome.
All right, great. We have a few questions here. A 70-year-old male and never had a colonoscopy. Do you still recommend it?
Yes. So if you've never had a colonoscopy at the age of 70, yes, the screening, you should have a colonoscopy, assuming that you don't have any other, comorbidities that would make anesthesia dangerous and so on and so forth. If you're a healthy 70-year-old, absolutely.
Okay. I'm soon to have CyberKnife radiation treatments. How long should I wait after the treatments to have a colonoscopy? Should I wait until the space or gel is eliminated?
I believe so. That is a question that you really need to discuss with your urologist, but that would be best, yes.
I know I have to talk to my primary doctor. However, I had a stroke and I'm using warfarin. How does it work with a colonoscopy?
Generally speaking, it depends. There's sort of a risk stratification that we use for any blood thinners and anticoagulation. That includes not just warfarin, but also things like Plavix and Pradaxa and so on. We always recommend that the patient discusses it first with the prescribing doctor, because it depends on how risky it would be to hold or stop the medication. With warfarin, the usual strategy is that if the warfarin was prescribed for something that's low risk, meaning that if you hold it, you're not at high risk for getting clots, then the standard is usually to hold it for 3 days and then do the procedure and then restart it. If it's a high-risk patient, then we do something called a bridge, where they start Lovenox. They hold the warfarin 3 days before start Lovenox, and then hold the last dose of Lovenox 12 hours before the procedure. But that's something that should be discussed with the prescribing physician. But it's not a barrier to screening. Similarly, I may as well just add that if you're on any other blood thinners like Plavix and Pradaxa and so on, again, you discuss it with the cardiologist or the vascular surgeon, whoever prescribed it. But generally speaking, you hold it for a couple of days before the procedure and then start right away after the procedure. The only difference it makes to us and to the patient is that it puts you at a slightly higher risk of bleeding than somebody who is not on those medications. So as a gastroenterologist, if somebody's on warfarin or Plavix or one of those, and if we remove a large polyp, that we think has the potential to bleed afterwards, we will usually put a little clip, or we'll make a little burn or something to try and ensure that it doesn't bleed afterwards. I hope that answers your question.
Okay, great. Yeah, that was a good one. What tests are available to actually see if a person needs a colonoscopy?
Well, the whole point of a screening procedure is that you're screening everybody. So you're screening a population that has no symptoms. So the whole point is that everybody at the age of 45 should have a screening test for colon cancer. The number one screening test that's recommended is colonoscopy. But if you don't want to have a colonoscopy, then you should have one of the stool tests. But everyone starting at age 45 should be screened for colon cancer. And if you have a family history of colon cancer, if you have first-degree relatives, that's a brother, sister, father, mother, who has had a lot of colon polyps, or there are certain other cancers like gynecological cancers, then you need to start screening early as well.
Okay, so 24 hours to the exam, you take Miralax, and then I can only have juice until the exam. I think somebody wants clarification on Miralax before an exam.
Yes, so you're on a clear liquid diet the day before the exam, the entire day, and then you start taking the Miralax. We also use a couple of Dalcolax pills, and then nothing to eat or drink after midnight. That's for anesthesia. So no solid foods the day before the exam. But you can drink all the way through. So the question might come up, what about if I'm a diabetic? Again, we would always want the diabetes doctor, the endocrinologist, or the primary care who's managing the patient to be involved in that. But generally speaking, because you can have liquids right up to midnight, you can usually continue with your diabetic medications with a few adjustments.
Okay, and your opinion about a 25-year-old female who has trouble emptying her bowels, and when she does, there is blood in her stool.
Generally speaking, blood in the stool is a symptom that all doctors take very seriously, but particularly gastroenterologists. The reason being that it could be due to something as benign as hemorrhoids or fissures, but it can also be due to inflammation in the colon, or or polyps, and even rarely in somebody of that age group, colon cancer is rare, but it can and has occurred. So I would suggest that you talk to your primary care and seek care with a gastroenterologist in order to determine if you need a colonoscopy. But I would take it seriously if you're seeing blood in your stool.
Okay. Somebody, I think, missed the slide. A 78-year-old and healthy, who should I contact for a screening? And I can share this screen that had that first slide, Dr. Rajapaksa, with your contact information.
That would be fine. Yeah.
Okay. So we'll do that. So I'll leave this on the screen for anybody who's interested in contacting Mather Gastroenterology with Dr. Rajapaksa. Another question here, am I able to drive after an exam?
Very good question. No, the reason being that propofol, after propofol, propofol sort of impairs your judgment a little bit. It's kind of like having alcohol where you think you're fine, but your judgment is impaired. So for 12 hours after a procedure, we do not recommend that you drive or operate heavy machinery or, make any major life decisions or anything like that. So no driving. For 12 hours, you have to have a ride home.
Okay. What are the risks of having a punctured intestine from the colonoscopy procedure?
Very good question. So the major risks of colonoscopy are perforation, making a hole, and bleeding. Making a hole is rare. If it does occur, then it's usually treated with surgery. If there's bleeding, the chance of bleeding, sorry, let me back up a little bit. If it's a very tiny hole, sometimes it can be fixed right away with clips, and there's lots of little instruments that we have. But if it's a bigger hole, or if it's detected later, then it's treated with surgery. The overall rate of perforation is about 4 per 10,000. It increases a little bit if there's removal of large polyps. The other major risk is bleeding, and bleeding usually tends to occur with removal of polyps. If we see that there's bleeding when we remove the polyp, we usually fix it right away with by putting little clips or burning. But sometimes what happens is that the patient goes home and they can bleed later when the clot falls off, particularly if there's a removal of a very large polyp. And in that instance, then you would come back in and we would again, fix it, put clips or burn it or whatever. But the incidence of bleeding after colonoscopy is about 8 in 10,000. That's the estimate.
Okay, we got 2 more questions here right now. And if anybody does have any more questions, please feel free to enter them. Somebody just missed what you had said on the Miralax. How close to the exam? They apologized. If you could just quickly repeat that.
Sure. So it really depends. In the old days, we used to recommend that the Miralax be taken in one go, but there was new data from the colleges that you get a better prep if you split the Miralax. So now we do half of the Miralax at about 4 or 5 in the evening, and the other half is taken about 6 hours before the time of your procedure. So, but when you're booking your procedure, you get written instructions regarding all of that.
Excellent. The last one's a little long, so please let me know if you need me to repeat it. I had a recent colonoscopy in November, and the doctor removed 2 polyps that were 25 centimeters and a few 6 to 8 in size. They could not remove the 35 centimeter polyp and sent me to a second gastro to remove that one. Is that usual? Shouldn't the first gastro have been able to remove the larger polyp? The mother got colon cancer at 68 and had several organs removed, but lived until 89.
Okay.
It's a long one.
Long one, but there are some polyps that are harder to remove. It depends not just on the size, but it also depends on the location, whether it's behind a fold, whether it's in a corner. It depends on whether it's very flat or whether it's raised or elevated, whether it has, so there's a lot of factors that one has to take into consideration. 35 is a large polyp. And so sometimes they require specialized equipment and specialized techniques to remove. And in that situation, we would send you to what we call an interventional endoscopist who have some other tools and toys with which to remove these. Now, bear in mind that in the old days, when people had these really big polyps that we couldn't remove endoscopically, we had to send the patient to surgery. But now, because of technological advancements, we can actually send a patient to an interventional endoscopist who has, like I said, more tools with which to remove these large polyps. Without knowing the specifics of the case, I would say that it's not unusual if you have a very big, difficult polyp to have to send you to an interventionalist rather than sending you to surgery. I hope that answers your question. And certainly with a mother who had colon cancer, a first-degree relative, and this particular person having many polyps, they are at risk for colon cancer.
Do you perform colonoscopies on on someone who has had a gastric bypass?
Yes. Yes, there's no contraindication to colonoscopies on anyone who's had a gastric bypass, or indeed anyone who's had colon surgery for any other reason. Say you had colon surgery for diverticulitis or something. Say one had a perforation once upon a time spontaneously or otherwise. That's not a contraindication to colonoscopy. And the other thing that patients sometimes worry about is if they have inflammatory bowel disease, if they have Crohn's disease or ulcerative colitis and the colon is inflamed, is that a danger during colonoscopy? And the fact is that in the majority of cases, it's not, because one has to do the colonoscopy for diagnostic purposes. It only becomes dangerous if the inflammation is very, very severe. Okay. I hope that answers the question. I added in a little bit more for other people who might be listening and interested.
Yeah, definitely very helpful. Somebody said review the symptoms that maybe one might have, I guess, when going to get a colonoscopy.
Meaning
I guess
symptom.
if you're asymptomatic and you're just going for your regular colonoscopy, others might be feeling symptomatic and realize they need a colonoscopy. What would those symptoms be?
So I'll answer all the questions related to symptoms just in case. So the majority of people who go for what we call a screening colonoscopy are asymptomatic. They have no symptoms. That's why they're going for screening. It's an attempt to prevent colon cancer by removing polyps, or to detect early colon cancer, which is asymptomatic, and when treated, that has an 80 to 90% survival. So that's the reason for doing a screening colonoscopy. Now, there are a lot of people who may have symptoms such as abdominal pain, any change in bowel habits, somebody who suddenly starts getting constipated or suddenly starts having diarrhea, somebody who's having bleeding, any of those kinds, or somebody who's noted to be anemic with a low hemoglobin, any of those sort of things would prompt a colonoscopy. Definitely would prompt a visit to the primary care and possibly a gastroenterologist. Now, if you're asking, are there any symptoms after the colonoscopy? I would say that sometimes the majority of patients have none. Sometimes we do pump in some air into the colon to open it up so we can see. So sometimes patients have a little gas pains afterwards. So unless you have a complication from the colonoscopy, like a perforation, usually the procedure is painless, and afterwards the recovery is pretty painless too, except for some gas sometimes. I hope I answer symptoms all around the question.
Yeah, that was great. That was perfect. Thank you. Does Medicaid and Medicare cover the cost of a colonoscopy?
Yes, all public and private insurers cover screening colonoscopies. Yes, Medicaid covers it, and so does Medicare. Yes.
Perfect. One last one here. I had my first colonoscopy at 50 and 4 polyps were removed. 10 years later, I had another colonoscopy and 7 polyps were removed. And 3 years later, the doctor removed 4 more polyps. That was just 2 years ago. Should I be having a colonoscopy every 3 years now? I'm in my late 60s.
Well, it seems like, I'm answering the question without having all the knowledge about the polyps, because there are many factors to consider when you're answering a question like that. For example, how big were the polyps, and more importantly, what was the pathology on the polyps? Because some polyps are completely benign and have no propensity to go on to colon cancer, but the majority do, and even within that group, some tend to be more risky than others. So, for example, a sessile serrated adenoma, as we call it, SSAs, is a little bit more dangerous than a regular tubular adenoma. So it depends on what sort of polyps were removed and the sizes, because a bigger polyp is more advanced and therefore is riskier than a smaller polyp in general. So having said that, if you had 4 polyps 3 years ago, I would say that you probably need one in 3 years. But like I said, I would need to really evaluate your whole story and look at the pathology. And the other thing that I want to mention is it also depends on how well the examination took place. There are a lot of variables. Sometimes there's stool in there, and even if the gastroenterologist really washed out the colon, they may not be really comfortable that they saw everything. We tend to be obsessive compulsive about this, but sometimes you might feel that there was too much stool that clogged the scope. You didn't see this, you didn't see that. In that situation, you might want to do it sooner as well. So many factors, but in general, I would say that it looks like 3 years for this particular question.
Okay, very helpful. And this is all, Dr. Rajapaksa says you're, guiding all of these people. It's totally based off not seeing anybody's direct health information. So, if you'd like to speak to her more, you're more than welcome to call the number on the screen, and she can get to know each of you a little bit better and, maybe better answer your questions. Looks like the last question we have here: does someone with hemorrhoids need to have those removed prior to a colonoscopy?
That's a good question. It's funny because we do get asked that a lot, and the answer is no. It doesn't impede or affect the efficacy of the colonoscopy. It doesn't make it any more difficult to do the procedure. The only thing is that, it can be more uncomfortable for the patient when they're prepping, because if you already have hemorrhoids, then when you're prepping and you're having a lot of diarrhea, that can make your hemorrhoids a little worse maybe and make you more uncomfortable. So what I usually suggest is that you get some preparation H and keep it at home so that when you're prepping, you can use it and stay comfortable. But the basic answer to the question is no, it does not affect the colonoscopy. In fact, we can study the hemorrhoids a little better because we also look at them from the inside, not just from the outside, to see how extensive they are.
Great. We also had a bunch of thank yous in the comment section. So Dr. Rajapaksa, thank you so much for taking the time today. That was incredibly informative. If you all could please fill out the survey you'll be redirected to, we'd really appreciate it, just to learn a little bit more about what you'd like to learn in the future. And if everybody could please just enjoy the rest of your weekend, stay safe and stay well. Thank you.
Thank you.